So we're going to take a few minutes to go over sort of a anatomy three-dimensionally using a pelvic model. It's never perfect, but it gives us basic concepts of understanding three-dimensional relationships, some of the vectors in physics that come into play when we think about suspension of the vaginal vault apex, or again, the cervix for the patients that still have a uterus in play. So we're all quite familiar in general with the anatomy. I always like to use a reference of understanding how we've chosen the anterior and longitudinal ligament of the sacrum, and then that actually gives us much of a very inline support system, right? So it's 12 noon. If you're standing on a cliff and want to be pulled up, it's an inline support system, and it's quite high, eventually, if you will, towards that sacral promontory. Now, once we go to a sacrospinous ligament, then everything changes, right? So now if we're there, which is quite lateral, and again, even if we use the typical one finger breadth over, you can see this sort of rectangular area I've demarcated here, the safe zone of the lower half, middle third of the muscle ligament complex. At this point, and these points are not even close, all right? So we have two big different vectors. Again, right here would be where my thumb is where you would attach for sacrocolpal suspension, but then looking way down here and over, that's not even remotely the same in terms of the physics of that, right? So big difference in splay. So if we want to emulate this vector and getting a midline, the more we walk more medially along the muscle ligament complex and go more midline and go more cephalad, we're at least going to get closer to where we want to be, right? So again, a lot of this was basic anatomical considerations to emulate the physics and vectors of support using again, a robotic sacrocolpal suspension with the anterior longitudinal ligament of the sacrum. So here, now we go more medially. We're using one finger breadth off of this edge of the sacrum of the coccyx, and then coming back this way and also going high. Yes, the inferior gluteal artery is way up and above in the greater sciatic notch. You want to be concerned not to go too far cephalad north. And again, we want to make sure they have one finger breadth off of the ischial, and they actually one finger breadth off the edge of the coccyx or edge of the sacrum right here. So that's basically the rationale behind what we've been doing. And again, it's very simple to doing a percutaneous approach. We are going to start with our finger on the ischial spine, just general reference point. Then we rotate down onto the muscle ligament complex, and we're going to sort of go down and up and off and on and just work our way on the inferior margin of the muscle ligament complex, pressuring to the floor until you finally will feel the edge of the coccyx and the bone. So there you know you've reached your sort of medial limit. That finger stays there as guidance. Our device, the amended anchor delivery system, comes in, and you're going to go just lateral to your finger. And again, you want to think about this is the north side, that's the south side. About the 50-yard line, it'd be about halfway up, is where we want to approximate the anchor. And just by putting some pressure there, the opposite, to like oppose the tissue, and then deploying just by squeezing, it easily drives through the vagina into that muscle ligament complex. You can see again the anchor now exactly where we intended it to be. It's quite easy to fire into that, and you cannot really get here, which is a preferred location, versus here by a traditional open dissection. This because of the soft tissue dystocia, a safe approach to get this more optimal location. And again, why are we doing it? To simulate and get closer from a vector of support to give us more of an inline support and more ventral support, also not to compromise the rectum. So this has been sort of the evolution of technique to optimize the anatomy with a sacrospinous ligament suspension and to optimize support to the vaginal cuff and or the cervix.